Hello, everyone. We're going to take some time now to talk about um, care of the patient with esophageal problems. Okay, and we're going to get this started here. There we go. So this is chapter 54. Again, this is care of the patient with esophageal problems, and it's chapter 54. Okay, alrighty then. So let's go ahead and get started with these. Your objectives will be to teach patients about lifestyle changes that can decrease GERD, alterations in comfort associated with hiatal hernias, perform a focused assessment on patients with esophageal health problems, implement nursing interventions to minimize stressors, and evaluate the impact of esophageal problems on a patient's nutritional status. So, gastroesophageal reflux disease, or GERD. It is the most common upper GI disorder in the U.S. Gastroesophageal reflux occurs as a result of the backward flow of stomach contents into the esophagus. Okay, GERD is the chronic and more serious condition that comes from persistent gastroesophageal reflux. The most common cause of GERD is excessive relaxation of the lower esophageal sphincter. And you will see that abbreviated LES. I'm not a huge fan of abbreviations, so I tend to not put them a lot in my lecture because I think we get so used to seeing um, abbreviations that we don't know what they stand for anymore. You will see GERD most often in middle age and older adults, but it can be at any age. But most often it is seen in middle age and older adults. So, what puts us at risk for GERD? Obesity is one of the biggest, and that's because it puts people at highest risk for the development of GERD because the increased weight increases the intra-abdominal pressure, which contributes to reflux of the stomach contents into the esophagus. People with nighttime reflux tend to tend to cause prolonged exposure of the esophagus to acid because lying down supine decreases peristalsis and and benefits from gravity. So these are two things that can cause problems with GERD. But remember that the one of the greatest risk factors for the development of GERD is increased weight. Okay. If you look at other factors contributing to the decreased lower esophageal sphincter pressure, we're going to look at table 54-1 on page 1088. When you take a look at that, it talks about other things that can cause a decrease in that lower esophageal sphincter pressure. A lot of times people with GERD will be told not to drink caffeinated beverages, to stay away from things that are acidy like citrus fruits, tomatoes. They're going to tell them to quit smoking. Um, a lot of times they'll have trouble with certain medications such as calcium channel blockers or nitrates. Um, they'll tell them to stay away from peppermints. Um, and again, almost everyone who has problems with GERD, they're going to tell them to stop smoking and to stop use and not to use alcohol because it does because of, both of those relax the sphincter, causing the GERD to be worse. Okay, so this is one of the things on the reasons that can contribute to GERD. On chart 54-1, again, still on page 1088, it talks about the gastroesophageal reflux disease, um, what some of the key features of it are. These people a lot of times will have dyspepsia, which is indigestion, that we talked about the regurgitation. A lot of times they have a cough and they'll have a real raspy sound to their voice just because there's been so much erosion to their esophagus from the amount of acid that comes up from their stomach. Sometimes they'll even have trouble swallowing. Um, as if GERD is severe, they'll even have the odonophagia, which is the painful swallowing, just because of the breakdown of cells from the erosion secondary to the stomach contents coming up into that esophagus. Okay, they'll have a lot of pylorus or heartburn. A lot of times they'll have this feeling like there's something in the back of their throat. A lot of times they will have problems with cavities just because, again, that breakdown of their, think about all that acid from your stomach, think about that getting up into your throat and into your mouth, and so causing all those issues because of that weakened sphincter allowing the acid back up into our esophagus. So what can we teach our patients about health promotion and maintenance? It's important to know that a lot of times people who have GERD may be initially asymptomatic. So we're going to encourage these people to eat a healthier diet, to lose weight, to limit their fried, fatty, spicy foods. You also want to limit acidic foods. And it's important for people with GERD to try to sit up for at least 1 hour after eating. That will assist in their digestion. So assessment or noticing. You want to ask questions like, do they have a history of heartburn or chest pain, asthma? Do they have a hoarseness in their throat? They have a history of pneumonia or dyspepsia. Their symptoms. When do they occur? With GERD, it's usually after meals, and it can last 20 minutes to 2 hours. The main symptoms are dyspepsia, better known as indigestion, and regurgitation. Other things can be belching and flatus, or dysphagia, or the odophagia that we were discussing earlier, which is the painful swallowing. Okay? Regurgitation is the backward flow into the throat of food particles and fluid. The risk for aspiration increases if regurgitation happens when the patient is lying down. You know, we've talked about dysphagia before. It is the difficulty swallowing. And remember, the odophagia is the painful swallowing, and it can be seen a lot in patients with chronic GERD. And the chest pain these patients have is atypical chest pain. It's not cardiac chest pain, but they will have pain in their chest. A lot of times they'll talk about a burning. They'll talk about coming up from their stomach. But remember, we always would rule out a cardiac issue before we would just assume that it was GERD. Okay? Remember, there is no definitive diagnostic test for GERD. A lot of times these patients will have a barium swallow because they're having difficulty. They want to see not only how food goes down, but also you can actually, when you see the barium swallow, they give them liquids and crackers that are tainted with barium, so you can see it on the x-ray. And if someone has GERD or regurgitation, you can really see it coming back up because it's that white milky look from the barium. It almost looks like an eruption. It's very interesting, or like a lava lamp. I think that's the best way to describe it. If you are too young to know what a lava lamp is, please Google it. Please keep in mind that pH monitoring is the most accurate method of diagnosing GERD. It involves placing a small catheter through the nose into the distal esophagus and temporarily attaching a small capsule to the wall of the esophagus during an upper endoscopy. Okay? The patient is asked to keep a diary of activities and symptoms over 24 to 48 hours, depending on the diagnostic method. The pH is continuously monitored and recorded. Okay, just keep in mind that the pH monitoring is the most accurate form, but that sometimes they will have an EGD or a barium swallow as well. Planning and implementation. So these are going to be some of the nursing interventions that we're going to be teaching our patients. Balancing nutrition is selecting foods to minimize GERD. Our goal is that the patient will have no reported reflux after meals. So what are some nursing interventions related to nutrition? Avoid eating 3 hours before bed. We talked earlier in the beginning in the psychosocial assessment that a lot of times GERD affects people's lifestyles. And this would be one of them, where if people wanted to go out for an evening meal fairly late, it could interfere with bedtime. So that's just something to keep in mind. Priorities when we focus our teaching is on teaching the patient about proper dietary selections and what does not contribute to reflux. A lot of times it can be very individualized. So a lot of times these people will keep a food diary to see what caused the reflux and what did not. They're also going to limit or eliminate foods that irritate the inflamed tissues. Part of the core measures by Joint Commission, you know how I like questions about the core measures by Joint Commission because that's where reimbursement comes in and that's how I get paid and that makes me happy. So the core measures for GERD with Joint Commission is smoking cessation and no alcohol consumption. And it's to make sure that these patients have been educated on that prior to discharge from the hospital. So moving on, staying with planning and implementation, we're going to want to improve their comfort. So what is the nursing focus? Is on teaching the patient about lifestyle modifications to alleviate pain. To prevent nighttime reflux, they may be encouraged to elevate the head of their bed or use a wedge pillow. Health promotion and lifestyle changes to control reflux are in chart 54-2. In this chart, you see health promotion and lifestyle changes to control reflux. It talks about eating 4 to 6 small meals a day, to eliminate fatty and fried foods, colas and coffee and tea. It's just not sounding very fun. Reduce or eliminate foods that are spicy from your diet, especially if they cause problems for you. And not to snack in the evening and not to eat anything 2 to 3 hours before bed. And if you really think about that, if you're wanting to eat as a family and, everyone doesn't get home until 6 or 7, that's very difficult sometimes for people to do. They also talk about not wearing restrictive clothing and to avoid lifting anything heavy or straining. And to chew chewable antacids thoroughly when you use them and follow with water so that it coats the stomach or coats the esophagus more. Now, there are drugs that actually can cause or be a causative agent to GERD. That includes oral contraceptives, anticholinergic agents, sedatives, nitrates, anything that dilates, that makes things come back up can be a problem. Now, antacids can be used occasionally, 1 hour before meals and 2 to 3 hours post meals. A lot of times will be helpful. Histamine blockers decrease the acid and are longer acting. Proton pump inhibitors are the main treatment for severe GERD and provide effective long-acting inhibition of gastric cells. Okay, so you have less acid in the stomach. A very small percentage of patients who have GERD do require surgery. Patient education, we talked about the dietary selections. We've talked about the medication regimens. Remember, they use antacids. They'll use proton pump inhibitors. That's the most effective for chronic, severe. And they will also use histamine blockers. So we also need to teach our patients about esophageal strictures, which is a narrowing of the esophagus, esophageal opening, and can lead to progressive difficulty with swallowing. The Bartlett's esophagus or Barrett's esophagus is where they have it's almost a roughing, and it's considered pretty malignant, and it can increase the risk of cancer.